Moving on to the last talk of this session, it's by no other than Dr. Francesco Pichi. He's a staff physician at Cleveland Clinic, Abu Dhabi, and he would be speaking to us on retina vasculitis, a comprehensive review and evidence-based treatment algorithm for inflammatory CNVs.
I think these are two topics combined together. So he's speaking on evidence-based treatment of ICNVs.
Okay.
I think two topics are it.
Yeah, that's what I was wondering, that this was really not making any sense.
I checked with him. I said, that's a complicated topic you've given.
So I can talk about one topic only in 2 hours.
So which one have you picked up?
Evidence-based treatment algorithm of ICNVs. Thank you very much. Very nice introduction. So it's a pleasure to be here. These are my financial disclosure, but they're not really relevant to the papers you're going to see. Inflammatory CNVs are the third type of CNV due to uveitis, and you all know that they're mostly associated with multifocal and PIC, and they're mostly type 2 because we're talking about young patients where the RP is very adherent to the brook, and so the blood vessels, they sprout through. Now, if you look at what's the cause, it's very different. It's quite different from wet AMD, because here you have a lot of inflammatory proteins and VEGF. In the pre-anti-VEGF era, there were steroids, PDT that you could use together with immunosuppression. But nowadays, we have a way to stop the inflammatory trigger and a way to stop the immunosuppression trigger. Now, if you look at the literature, there's a lot of paper, retrospective case series, and what's fun is that they use a lot of different ways for these anti-VEGF. Some goes PRN, some load, so there's no consensus, and the only prospective study that was done was the Minerva study that was supported by Novartis at the time, and it's for ranibizumab in everything else that's not wet AMD and DME. And you can see here the results, but it's not really telling us a lot about inflammatory CNV. So overall, anti-VEGF are very effective, and they control, but the control of the underlying inflammation is very, very important. There's tons of different regimens used, so which one is the one that we should use? So we're going to start by presenting a paper that we published on BJO together with Alessandro, and I believe Dr. McCluskey was also part of this. Here, we compare two regimens of anti-VEGF, one loading and PRN, and the other one PRN. We looked at the outcomes of the vision, and we looked at the number of injections and the number of recurrences. So all the patients were treatment naive, so no bias in that. And then, as I told you, two groups. The one had 3 monthly loading and then PRN. The second one went PRN from the start. Now, this is the best corrected visual acuity at baseline in the two groups, very comparable. These are the causes of the inflammatory CNVs, and these are the results, which are the most important. You can see at 24 months, the changes in best corrected visual acuity and the changes in the number of letters, they are very comparable between the two groups. The dotted line is the PRN, and the other line is the loading plus PRN. So there's no significant difference in best corrected visual acuity at 24 months between the group that was loaded then treated PRN and the PRN group from the start. What about the number of anti-VEGF? It doesn't take a genius to understand that if you load the patient, you get more injections done. So here you can see in the loading group, there's a mouse here, yes. In the loading group, there's a higher number of anti-VEGF injections at 12 and 24 months. So overall, the loading group received more significant number of injections compared to the PRN group, both at 12 and 24 months. What about the recurrences? They were quite few in both groups. See, both in the loading and the PRN group, they're very comparable. So no significant difference in the number of ICNV recurrences. So it has some limitation because it's retrospective, it's not standardized treatment, but it's a start for us to tell that patients can be treated with anti-VEGF PRN when they have inflammatory CNV. Anti-VEGF were effective in our group, and the loading phase did not give any advantage to patients treated PRN from the start. So PRN seems to be the best way. But what about treatment? Because we are injecting, but at the same time we are treating the patients systemically. So we just published this paper where we are evaluating patients with inflammatory CNV divided in two groups, one treated with steroids, PRN, and the other treated with the immunosuppression. Now these are the baseline characteristics, very comparable between the two groups, between the steroids and immunomodulatory group. The results, best corrected visual acuity at 2 years, you can see straight away, you can see from here that there is a slight difference between the group that was treated with steroids and the immunosuppressed group, but you can see it much better here. If you look at the green line, these are the patients who received immunosuppression, and they gain many more letters compared to patients who were treated on PRN oral steroids. And it's same thing for the change in visual acuity from the baseline. What about the number of recurrences? You will see that patients who were treated with steroids PRN, they have a higher number of recurrences compared to patients who were immunosuppressed. So this is the number of recurrences reported in a graph. Steroids as needed has a higher number, significantly higher number of recurrences compared to the patients immunosuppressed at year 1 and more at year 2. And of course, the number of anti-VEGF injections that were used were higher in patients that were treated with PRN steroids compared to immunomodulatory treatment. And here is the Kaplan-Meier. So if you immunosuppress a patient, the recurrence of inflammatory CNV takes longer to happen. So in conclusion, immunomodulatory treatment was associated with lower reactivation of ICNV, lower need for injections, and better visual acuity compared to just using steroids oral when needed. So immunomodulatory treatment should be considered in all patients with multifocal choroiditis, especially those that have an ICNV, given the great positive impact. And with this, I thank you very much for your attention.
Thank you, Dr. Pichi, for that